just a little bit about myself, and I'll turn it over to David to introduce himself and talk about some exciting things that happened here in Texas in the free market space and what he has to share. I am what I like to call a recovering state employee. I was on staff for state government for about 7 years. And during that time, I had a front row seat to the impending doom that healthcare was bringing to the financial costs of the state of Oklahoma. Just to give you an idea, I told you I'm going to do my best to not bore you with numbers, but our state's Medicaid budget had risen from about, the state share had risen from about $300 million in 1995 to over $2.3 billion just 20 years later. Now the total program in the state's total cost is a total of about $6 billion. And that's in little bitty Oklahoma, and can't imagine what's happening in Texas. So having that front row seat to that and the Medicaid welfare program, and then having the front row seat to the enormous growth and cost in the state's state employee health benefit plan is what led me to begin looking at what was going on with healthcare costs. And so that began my journey, along with 2 or 3 brushes with bad hospitals that our family had personally. So when I talk today, I'm going to talk a little bit about the good news that's going on and then some of the bad news and where we should go from there. David, you want to talk?
Good morning, everybody. Can you hear me? Is it on? Thank you very much. Jonathan's, I have a great deal of admiration for what he's doing in Oklahoma, and thankful for the work that they do. My name is David Balat. I have a little bit of a different background. I've come from the hospital industry. Is it not on? Yeah? Okay, you're welcome. Group practice manager, healthcare executive, hospital CEO for nearly 20 years. Really got into it because, what I say is my parents immigrated to this country, so I was destined to be a doctor, but it didn't work out that way. But I worked in the hospitals and just had a love for patient care. I loved working with the patients. And the administrative route was the way that I found that I could partake in that process by letting doctors be doctors. And I did not play well in those big box organizations because they ended up being glorified hotel managers. So I ended up doing hospital turnarounds in rural communities, rural hospitals, community hospitals, county hospitals, physician-owned hospitals. And by the time I got there, they were in financial distress, and I would get them back on their feet. But how did I do that? I worked with the doctors. If you provide a place where there's a safe place for their patient to get the care that they need, it's really not rocket science. Healthcare shouldn't be as complicated as it is, but it's intentionally done that way. Well, how did I get here? I was off my meds one day, and I decided I was going to run for Congress. And I did so in Houston, and I ended up losing in the primary, thankfully, to a gentleman that's currently in office, Dan Crenshaw. And after losing in that race, I had the opportunity to go back to work, and I really couldn't do it. I'd spent the last year talking about how horrible healthcare was, and it was. And I didn't really feel like I was contributing to patient care anymore. I wanted to be a part of the solution. I just didn't know what it was. But after Dan won his runoff, he said, "Dave, you kicked my tail in every debate when it came to healthcare. I'd like you to help me." So I started looking for opportunities where I could do that with other lawmakers. And so I did that. And over time, just somehow got the attention of my current employer, Texas Public Policy Foundation, and been there for 2.5 years. So policy is just, for me, it's been my vehicle to do what I want, what I set out to do initially in the hospital business, to make healthcare more patient-based, to embolden and empower that doctor-patient relationship. So that's how I got here. So let's talk about what we did in Texas. Can everybody hear me? Everybody comfortable? It's a little warm in here. We're good? Okay. What was the biggest issue in Texas coming into this last session? It was Medicaid expansion. The single biggest component of the Affordable Care Act is Medicaid expansion. It was supposed to be a foregone conclusion, right? It was going to be a mandatory component of the Affordable Care Act. It got struck down, that component got struck down in the Supreme Court level, and so states could opt in if they so choose. Well, a number did not, and prior to this session, there were 12 holdouts, Texas being one of them. There was an incredible amount of pressure, not just from the left, also from the right. The arguments had always been, well, why do you hate people? Why do you not want them to have health care? And let me just say this. Nothing irritates me more when I hear a politician, and I'd love for this to be a trigger in your mind. When you hear a politician use the word healthcare and how it's being taken away from you, understand that they have no idea what they're talking about. It's not healthcare, it's health insurance. And they conflate the terms of healthcare and health insurance, and that should not be the case. So we really had to flip the script. And we looked at the research, we provided the data, but we also included the stories because we needed to share at an emotional level to explain that, look, I've seen in the ERs, who is in there predominantly? Medicaid patients. Why? They're using it like their doctor's practice because they can't see a doctor, because doctors aren't getting paid at a fair rate. It's taking 2 to 3 weeks to get in there. It's just not a good system for those for whom the program was intended. We point to a number of different studies. Oregon it was the Oregon Medicaid project. The final analysis was having Medicaid was equivalent to being uninsured. So what is the benefit of expanding Medicaid? What is the benefit to the patient? The other negative impact is that you're going to be crowding, by bringing all these other folks in, you're going to be crowding out those for whom the program was intended, right? You've got healthy people crowding out sick people, poor people, people that need the access in the safety net. So when we started talking about that and telling those stories, the other side, the left and those on the right that were pushing for the expansion, did exactly what we wanted them to do. They said, well, we're leaving money on the table. We don't want to miss out on those dollars. As if there's a stack of cash sitting on a table somewhere waiting for us to pick it up and use it. There isn't, by the way. So there was an incredible amount of pressure to expand Medicaid in Texas. And as I said, it was coming from both the left and the right. In addition to the pressure to expand because of the 90-10 split on the expansion population, there was an additional bribe offered by the federal government. They were going to add an extra 5% to traditional Medicaid, which is a huge, huge piece of our budget. And so people said, yes, let's do it. That's even better. That's more money. Let's get it done. We worked very hard, and I'll tell you, at the beginning of this year, even the Speaker of the House, a Republican, and a number of Republicans in the House of Representatives were talking about, it's time to do it. We need to expand Medicaid. And we went to them and we said, look, we can't do it. And they said, David, we can't just shoot everything down. I said, I agree. I've been talking about these solutions for years. Let's go on offense. They said, okay, let's do it. So we put together a bipartisan approach called Healthy Families, Healthy Texas. That was on April 7th. And we'll talk about what comprised that plan. But as soon as that was announced, and you had the Democrats and the Republicans and the Speaker talking about what was in this plan and how it would help people and what it would contribute to the existing Medicaid population, a week later, we get word from CMS, and it was the rejection of our transformation waiver to extend Medicaid for the next 10 years. It had already been approved. We submitted our application December 15th. It was received on January 15th. It was accepted on the 22nd. It was approved for 10 years. And then they came back and they rejected it. Did they reject it for the substance of the application? No. It was some procedural issue. Since I put this slide together, some other things have happened. On the 15th of this month, or last month, the Attorney General of Texas has filed a preliminary injunction against the federal government. and we contributed in an amicus brief to support that injunction. And we've also submitted an application, a subsequent application the state of Texas has, to get that transformation waiver for Medicaid, and CMS has acknowledged receipt. That's all they've done. So that's where we are. The Healthy Families, Healthy Texas plan was composed of 12 bills, but it wasn't an omnibus. Each one was individual. They stood on their own. This is a list of, and I think everybody's going to be getting the slides. 7 bills were Republican, 5 were Democrat, 9 were passed into law, and it was a mix of both. I think it ended up being 6 Republican bills, 3 Democrat bills. The problem, as soon as we moved forward with that plan and we pushed for support, people came out and said, well, these bills really aren't going to do anything. The impact will be very small. If you really want to help the uninsured in Texas, you need to expand Medicaid. And we put out as much information as we could to explain that that's not the case. Whereas expansion was really going to be 1.1 to 1.5, and in fact, the number ended up being 750,000. The Healthy Texas plan served more like 4 to 6 million and cost $200 million versus the $5 billion in the Medicaid expansion program. See, I talked a little bit about the Medicaid expansion and what's going on. The Medicaid expansion push was to fix the uninsured problem in Texas. We have the highest number of uninsured people in the country. We looked into that. And the CBO has also done a study. It's really only 7% of that total number of uninsured that is truly uninsured because they don't have a choice. Everybody else, 600,000 people are eligible for Medicaid but choose not to enroll. 1.5 million people are eligible for the ACA with subsidies and choose not to enroll. Close to 2 million people have the option to take their employer's health insurance. They choose not to enroll. They've chosen not to take those insurance products. So are they uninsured? Yes, by choice. When we talk about the uninsured, the idea is, well, they're uninsured because they don't have any options. They don't have any choice. That number was only 700,000 people. So rather than apply a one-size-fits-all solution, let's identify the breakpoints and develop solutions for the people in a proper and true safety net. I know I said that there were 9 bills that were passed in the plan. I only have 8 here because I only took credit for mine. I'm going to be selfish. Telemedicine, of course. We did some things to fix Medicaid because one of the message points was, let's not expand Medicaid, let's fix it. Because it's not working well, it's broken. It's poorly performing. Let's improve it again for those that want to use it properly and improve upon their health. Licensure reciprocity, let's allow for a program where we can bring more doctors and nurses into the state as opposed to exporting them to other states. The Farm Bureau and Texas Mutual bills, these were, well, the Farm Bureau, let me talk about that. They work very similarly, but let me focus on the Farm Bureau bill. Every state has a Farm Bureau. In Texas, they have 500,000 members representing 1.5 million belly buttons. I saw that term earlier this week, and I liked it, so I'm going to steal it. So 1.5 million people, and they used to offer health benefits. They offer all kinds of insurance to their members. They had health benefits prior to the ACA and stopped when the ACA came into being. That happened to a lot of organizations. What Tennessee has done is they offer health benefits, but the state has allowed them to sell health benefits but not be considered an insurance company so that they are not under the regulatory authority of the Department of Insurance. Well, why is that important? It's important because if you're not seen as insurance by your state, then you don't have to comply with the ACA rules. So they could offer plans that are consistent with the needs of their members. So that was a big deal, and there was a lot of pushback from the insurers and the ACA proponents, because in their mind, the only thing that should exist are ACA plans and Medicaid expansion. prescription drug saving program for the uninsured. And then, of course, the hospital price transparency. I spent a lot of time in DC for the executive order, and I was disappointed with the penalty that was attributed to non-compliance, and we see that there has been a lot of non-compliance by the hospitals that don't want to put their negotiated rates online. And I agree. I think Jay mentioned on the first day how we're concerned about how things are defined. Transparency is not an estimated rate. Transparency is not a range. Transparency is not your gross charge. Transparency is the price. If I am an Aetna patient and I need to go get a CAT scan, and I have 2 hospitals in network, I need to know what the negotiated rate is between Aetna and these 2 hospitals so I can make an informed decision. If I have a $5,000 deductible, I'm a cash patient, right? So if this hospital's part of a big system, they're able to use their market leverage to negotiate a $2,000 CAT scan, and this one over here is a one-off, and they can get it for $750. Where am I going? That's a pretty easy decision, is it not? Even if I have to drive a little further. So transparency is important for people to be able to make informed decisions. Seeing the level of noncompliance after the federal order, we decided to codify it at the state level. And we took it to some champions in both the House and the Senate. And we looked at the polling, and we looked at the messaging, and we looked at the language and what we wanted to do. And I'll tell you what I'm proud of. And we're going to talk about this in one of the next slides. It was not a partisan issue. It became about the patient, because the patients became involved, because in doing the polling, guess how many of 100, let's just say out of 100 people, how many people do you think want to see the prices? What do you think the polling came back at? It wasn't 100, it was 90. It was 90-10. It was a 90-10 issue, which means both Republicans and Democrats and independents and whoever else you want to identify as decided, yeah, that's important. So it came out of the Senate committee unanimous. Went to the Senate chamber, came out of there unanimously. Went to the House, went into public health, voted out unanimously. Oh, they made a change in public health, which I thought was very good. Instead of it being a flat, fixed fine, which the concern there is the threat of consolidation. Big hospitals could eat up the little hospitals. What they did is they had a sliding scale. The bigger you were, the more revenue you made, the bigger your fine. And we actually reduced it for the smaller hospitals. So tried to eliminate or mitigate against that threat. Came out of there unanimously. Went to the House floor. Want to take a guess? I expected some no votes, to be honest. Again, unanimously. And so signed by the governor and going into effect next month. So we're very proud of that. But we've heard it before. I've had a lot of conversations this weekend. Transparency alone isn't going to be the solution. It's the necessary first step. I can't remember if it was you, Dr. Byland, you talked about the travel agency or travel business, the airline industry. We didn't go from prices being disclosed right to Travelocity. There were a lot of steps in between. And I see that situation for healthcare as well. In order for us to get to bundled pricing, like what we see at Surgery Center of Oklahoma, we need to have the transparency of pricing initially. But there are things we need to do in the meantime. And I think there's some good work that's being done in Oklahoma. I think Jonathan's going to talk about that. Ultimately, we've got to get away from the weaponization of healthcare. Healthcare is personal, not partisan. But it's a political football, and it will continue to be used that way until we make them stop. I'll leave it there and take questions after Jonathan has his piece.
Thanks, David. Okay, I'm going to try to move fast because I know I saw you raise your hand with one question, so we want to get to questions. But just so you kind of landscape what's going on in the country, there are approximately, in the last year, there's been about 27 bills passed in 12 states dealing with all kinds of things, going anywhere from scope of practice issues, dealing with licensure. There was a pretty significant movement happening in states on telehealth due to the pandemic. So where there'd been a lot of opposition prior to 2020, there has been much more reception to that. So that's one of the good things about all of our lives being confined to Zoom, or what's the Microsoft platform called? Whatever it's called. Teams, yes. The result of that is our lives now suck doing work, but the good thing has been telehealth has now taken off. So one of the exciting things that's happened, and I think this is a testament to what many of the providers are doing, or sellers as we call them here, has been the expansion of the direct primary care movement. About the time that FMMA started, there were only about, I think it was 8 states that had some specific state protection for the ability of a doctor, so a seller and a buyer, to purchase individually. Employers could do it, but it was very difficult for an individual, a family, and say their doctor. Furthermore, because you hear Jay and Keith talk about this all the time, government tends to be the greatest weapon of force used by the trolls. And so there was a movement not long after the Affordable Care Act passed by some states to actually proactively pass legislation that would prohibit you from individually contracting with your doctor. So FMMA, the State Policy Network, I'll talk about that in a little bit, all began to work together to promote this kind of foundational concept of primary care. Happy to say that over a period of about 6 or 7 years, there are now 32 states that have specific protections for direct primary care. I think another 12 states are looking to add to that number. So that's an exciting thing that's going on. Let's talk about some things to be aware of, and then I'll tell you a tale from Oklahoma. So you're hearing great things from Oklahoma about what's happening in the buyers and sellers space. I've got some news, though, to tell you about some things that aren't so great that demonstrates how much for lack of a better term, the trolls are trying to push back against what you guys are meeting about this weekend. So one of the fast things that happen, you heard David talking about it, this issue of price and hospitals. So in Oklahoma, I'll give you an example. In Oklahoma, there was a liberal news reporting group. They had ulterior motives for reporting out about this, but in little bitty Oklahoma, there were over 22,000 lawsuits filed by nonprofit hospitals against patients. So these are hospitals that have, because I felt like you were going to identify better if I read this to you. So let me give you an example of the mission statement of one of the hospitals suing thousands of people. We extend the compassionate ministry of Jesus by improving the health and well-being of our communities and bring good help to those in need, especially people who are poor, dying, and underserved. Their values are dignity, excellence, justice, service, and stewardship. So I'm going to talk a little bit more about this seller in a little bit. So we decided that we needed to work on the side of the equation that is allowing the big hospital systems to get away with their pricing scheme on an individual matter. And that is that they don't tell patients a price. Patients come in, they have a procedure provided. Magically, they don't know or understand what the cost is. And then magically, as soon as they have done the procedure and the patient leaves, the patient gets attacked through the mail by all these bills that they couldn't come up with beforehand. So I see Jay back there. Jay probably remembers, we had a long conversation. So how do you tackle this problem without putting government in the position to determine price. So I'll talk about that's one of the trends that we need to be careful of. I'll talk about that in a minute. So we came up with the idea. So think about it. How does a hospital do this? Well, there are wage garnishment laws that are generally on the books in each state, and then they are essentially using the court system, filing a lawsuit, and then putting those judgments on people's credit reports. So we just had a simple bill. It was Senate Bill 548, simple concept. If you do not tell the patient the all-in total price before the procedure is performed, then you are not allowed to use the Oklahoma court system to pursue lawsuits against a patient, nor are you allowed to share the private information between you and the individual about what the price was, especially since you couldn't figure out what the price was before it. As you can imagine, the Oklahoma Hospital Association lost their minds. The number one opponent of that legislation was Mercy Hospital. Let me read to you again Mercy Hospital's mission statement. We extend the compassionate ministry of Jesus by improving the health and well-being of our communities and bring good help to those in need, especially people who are poor, dying, and underserved. Remember their values. Let me just remind you again. Dignity, excellence, justice, service, and stewardship. They actually hire a lobbyist in session specifically to work on killing this legislation. It passed out of the Senate overwhelmingly. Then it went to the House of Representatives, where the trolls have a greater foothold. And unfortunately, that legislation stalled there this year. But that's an example of how adamant. It's we heard the presenters at the plenary session that we just had over breakfast, how serious the hospital system is about maintaining control. Who can object to the idea that you shouldn't be able to sue someone in court or ding their credit report if you wouldn't show them the price of the product beforehand? How radical? I mean, there's nothing radical about that at all, except for the fact that if that had passed, it would have had a significant impact. So I want to open it to questions, but want to mention a couple of threats that we see coming on the horizon. So actually was talking about this with Jay and Keith in May. So there's been a lot of awareness about the problem of PBMs, pharmacy benefit managers, which is good. The problem is, across the country, the answer is becoming in the legislature to essentially use the arm of government to dictate how a PBM operates, but in particular, really what they're trying to do is set prices. So for example, there's a bill, not going to mention the lawmaker's name to be nice to that individual, but recommended requiring that prescription fill rates be more than 6 times what the average were. And this was being born out of the local pharmacists association and others saying, hey, it's not fair. We're being mistreated by Walgreens and Walmart and everyone else. Why don't we get the detaining police power of Oklahoma government to help us and set the price that we want? So those are the wrong trends. I mentioned the State Policy Network. So I would encourage you, just go to www.spn.org. There you'll be able to get connected with what's known as a state-based think tank like TPPF in Texas here or OCPA in Oklahoma. And those groups are doing a lot of the work intending to try to be based from a free market perspective. So that's the first threat. We need to be aware of what's going on. One more time, www.spn.org. SPN stands for State Policy Network. But a lot of the doctors here in Oklahoma are connected with the Oklahoma Council of Public Affairs, and a lot of doctors from Texas I know are connected with Texas Public Policy Foundation. So a number of the good pieces of legislation that we have passed in Oklahoma, it's been directly because of the think tank I work for, OCPA, and our partnership with Keith and a number of the doctors in Oklahoma. So I mentioned that first threat. We need to be aware of the temptation by lawmakers to use the arm of government to try to exact these inequities as it relates to PBMs. I think the next area where we need to be really careful and be aware is not taking healthcare price transparency so far that you end up putting government in the position of dictating price. Once that happens, all our efforts are going to be worthless because government has demonstrated how good it is at setting prices, hasn't it? All right, with that, so I think I saw one question here, and then we'll go back there, and either of us can answer it. Yes, ma'am.
I'm just curious about the Texas Department of Insurance, because I'm always telling people, well, we should complain to them, but should they do anything, or do you know anything about?
Yeah, absolutely. It's tricky because they only have the regulatory authority over fully insured plans. So if you or your employer pays a premium and Blue Cross functions like an insurance company, yes, you can make that complaint to the Department of Insurance. However, if your employer is self-funded, the Department of Insurance, any Department of Insurance, does not have the authority over that plan because it's an ERISA plan, so it would be the Department of Labor at the federal level.
Can they do anything?
They're not as responsive because it's the federal government. Yeah. Do you have what? You could probably speak to that, Jay.
Unfortunately, yes, I can speak to that. Yeah, they are. They would be much more eager to be critical in regards to your plan, actually, to self-funded plan as opposed to being sympathetic. It's very unfortunate, but it does seem like the DOL just doesn't understand the rights of a plan sponsor that's actually their nickel. They do tend to look at employer-based plans almost like the big bad insurance companies, like we're somehow part of the problem.
My experience with the DOL is that they are not really well versed in the healthcare language within ERISA.
But does the Texas Department of Insurance do anything now?
Not if it's a self-funded plan.
But I'm saying with their other plan.
With insurance companies, in a fully insured example, yes, they do. They have an enforcement arm, and they've been pretty responsive. I can't say that they haven't. They do respond to complaints.
What's your ordinary question, like for patients' issues or?
Right, if they have an issue getting something covered and they're fighting and they can't get anywhere.
Something
So you say, well,
trying to get something done.
Yeah. Any other questions? Yes, sir.
I'll give you this.
I've got two questions. First one,
There's two of us.
yeah, good. You're saying price transparency, I guess that passed in Texas for hospitals. What is the number, or let's say a knee replacement? What number are they going to put out there? Or what number are they going to be required to put out there?
There's no requirement. It's the hospital's price. It's their negotiated rates. So if I'm a hospital and I have negotiated rates with Aetna, Blue Cross, Cigna, Humana, United, I need to put my rates out and publicly disclose them. Government is not dictating what the price should be. They're not price setting. We would be opposed to that.
But I'm just asking, are they just putting out one rate? It's maybe a blended rate, or are they putting out a cash rate? What was in the legislation?
Cash rate, negotiated rate, 300 most shoppable services, but the hospital could choose what those.
Okay.
Yeah, which is pretty useless. Yeah, well, some will say, well, that's just our charge master's list price, which that's a work of fiction. So those are meaningless. The most important component of that law is the negotiated rates with the insurers. Well, I want to let him finish his questions if I could.
Okay.
And then we come to
I mean, I run ASCs. I guess that wasn't considered.
not included,
Not included. Okay.
unless you're part of a hospital system.
Okay. And then my second question, they gave us 267 codes last year, and they're trying to take back, and that was under Trump, obviously, but now they're trying to take back 258 of those. Do you guys work on that, or how does
I'm not sure I understand your question.
CPT codes that were moved to ASCs,
Mhm.
which makes it cheaper for the procedure to be done? They approved like 267 last year, and now they're trying to take back 258 of those.
Under the new administration?
Yeah.
Well, I think that was an effort to say we want more work to be done in the surgery center because you can get more cost-effective care.
Yeah.
There's lots of ways. ASCs, for some reason, is more complicated. The revenue cycle or the reimbursement models are more complicated because you have groupers and you have Medicare and you have CPTs and you have all kinds of different things. No, I think that's incredible pressure by the hospitals to keep that business away from the ASCs.
But I mean, do you guys work on that piece too? Or?
That's the federal level.
Yeah, I mean, I think I'd say that I'm glad you brought that up. We'll go back. David and I are part of a healthcare networking group within State Policy Network that probably has about 15, 16 think tanks that are working on that. I'll make a note, but I'll tell you it'll be difficult. I mean, because there's an unholy alliance between the hospitals and the current administration. And to the extent that the Biden administration has the ability to impact that area, we're going to be limited in our effect unless you could get a groundswell of the public yelling and screaming at their local congressman that's happening. I mean, that's what you'd have to have an overwhelming sense of outrage. So, but we'll talk about maybe another way to do that. Yes, sir.
Well, and I was going to say you could use Biden's own words against him. He said he was pro-competition, so why not allow for those surgery centers to compete with the hospitals in outpatient surgery?
Yeah.
Yeah, the program was called Hospitals Without Walls, and Oklahoma became the second state after South Carolina for Governor Stitt to end that exemption and at the behest of the hospitals to not allow those codes to be done at surgery centers. I mean, it doesn't apply to SCO because they don't take Medicare, but other surgery centers were taking care of Medicare patients, and there was supposed to be a 60-day wind-down period. The government had already extended it to October of 22, and Stitt on June 15th, signed an executive order ending that program in the state of Oklahoma. So it's keeping a lot of patients. I mean, we've called various senators and Charles McCall and all kinds of people trying to, what prompted the governor to do that, and he, no answer other than the hospitals.
So I have a quick question on the pricing transparency function. So federally, they're required to do that now, right? Mm-hmm. My local hospital gives like a text file, like the old school like text. You can't do anything with it. Like, is there any teeth to that's bullshit. Like anything in the Texas laws that prevent that stuff from happening?
The law has been signed. Where the real magic happens is in the rulemaking. And that's the process that I'll be spending a lot of time in, how the data is going to be provided, how it will be disclosed, because there's been a lot of game playing. Who saw the Wall Street Journal article about how the hospitals were putting junk data in there to make it unsearchable? So, yeah, it's right in line with their mission.
Yes, exactly.
I think so. But what we're seeing happen is exactly what we thought would happen. You're seeing companies like Turquoise, Health Cost Labs, that are pulling this information, hiring programmers, cleaning up that junk, and putting out that data in an easy-to-understand format. We just don't have a lot of compliance yet. Truth be told, we thought it was around 30% compliance. It's actually less than 10%. And who are the biggest non-compliance groups? Who are the biggest culprits? It's the big systems. They have the most to lose.
Well, and that's why we arrived at in Oklahoma the law that we arrived at. Because if they can't get paid, that's ultimately what will make them start actually being honest about price. And we felt like our reform was kind of right down the middle of not having government dictate a price, but just saying you can't use government's police power now to enforce on your scheme. If you think about it, it's kind of like a mafia, and Guido is the court system and the credit bureaus. Yeah. And so we feel like that's kind of the next stage where a lot of states are going to have to go to, is banning the ability for providers to go to, if you're not going to show a price up front, that would be a violation in just about any other industry going on in any of the states that we're from. If you tried to charge someone for something without telling them the price up front. So anyway, great question.
Yeah.
Yes.
Is there any new listed claims data transparent?
So I think the challenge with claims data, making claims data transparent, is unless it would be aggregated data, you'd have HIPAA violations and contract violations between the employer and the plan. And so I think that could be helpful, but the challenge has been, it hasn't really mattered what we've asked them to publicly report. They're just not doing it. And so we've got to get to something else that's going to force them to actually do it. And that's one of the things I was going to say, is that all of these reforms that we're trying, they're all secondary to what you guys are doing here, which is willing buyers, willing sellers getting together and saying, what should the price be, and exchanging value. That's the number one way to put pressure. So I know you guys were working in Texas, we have in Oklahoma. One of the things that we've been trying to do is, so who's one of the biggest buyers in each state? It's the state government apparatus, a combination of between their Medicaid programs and their state employee health care programs. That's billions and billions and billions of dollars. So we had promoted with success the purchasing of bundled priced healthcare in Oklahoma, and it was performing so well that after a year, the hospitals prevailed upon the state's health insurance plan and ended it. You guys will love this. They came in and they said, look, we're paying more than 165% of Medicare for someone that goes to a place like the Surgery Center of Oklahoma. But all of our hospital, the average price that the state is paying for healthcare at a hospital is under 165% of Medicare. Well, if you know anything about the black box and the insanity that is the Medicare pricing list, it's that in Medicare, they massively increase what the rate is that would be paid to a traditional hospital versus ASCs and independent surgery centers. And so I think that that's a way to begin to put pressure. The reason that the hospitals attacked us on that plan is there's over 200,000 lives in the state's health insurance plan. If we had gotten the state's health insurance plan on bundled pricing for a couple of years, that would have been game, set, match in Oklahoma, because private taxpayers would be going, how the hell did the teacher get their knee replacement for $5,000 all in, but I paid $25,000? And so that's kind of I think where the next stage is in states that have been more friendly, so Texas, Oklahoma, and others, beginning to have state governments using their purchasing power. And again, that's a way to force change on the market or the system without having government intervening in the private business to private business relationship.
Did we do that great a
Other
job?
questions?
Yes, sir.
Thank you all very much. We get several calls, Keith and I both do, from members of the FMMA around different states, and they always want to know, God, who can I talk to? Is there anybody that can assist me? Because there's this bad legislation that's being discussed, or is there anything we can do about it? And so, these in Oklahoma and Texas, these are the guys right here. I would encourage you, though, that there is a OCPA, there is a Texas.
TPPS.
There you go. In every single state, please go out to that state policy network. That is really kind of the association of these state associations, and find out who is the organization within your state. Reach out to them and get to know them and support them. That's what you can do. I mean, because OSIPA has been invaluable to what we're doing in Oklahoma. Not that we're ever looking for, solutions through government, but they certainly can influence. If there's a piece of legislation that's coming down the pike, they can at least make us aware of it. Maybe we can get it tweaked a little bit where it is less damaging. So that would just be my advice to everybody here.
And I was going to say something. You'd asked a question earlier about the insurance department. So I actually worked at the insurance department in Oklahoma. And it, unfortunately, like any bureaucracy, it just depends on the day and who gets that claim that you're asking about. One of the great things that's going on, not great as in good, but enormous, is the fact that Blue Cross Blue Shield and Humana and several others, so they have recognized that people kind of understand, especially employers understand that the game or the jig is up on the fully insured side. Yeah. So the business over the last few decades in Blue Cross Blue Shield and several others on the self-insured side is enormous. And here's the problem with that. They take that same gamed system network PPO that they have on the fully insured side, and they're laying it down on the self-employed side. And then the consultant, no offense to consultant or broker, is coming in and saying, hey, so-and-so employer with 10,000 employees in Oklahoma, did you know that you can have a self-insured plan that is attached to the Blue Cross network in Oklahoma? And so we're seeing that as a growing problem. Jay and I were meeting with one group, and they were talking about this. So the plan is self-insured. Their third party is Blue Cross, and Blue Cross is refusing to give them claims data. And it's their claims data. Mm-hmm. They're the employer. It's a self-insured plan. And, likely what happened is they signed something that says they won't get it. But Blue Cross doesn't want them to have that information, because if they have that, then they're going to have information about the prices that they're charging in their network. And I don't have to repeat it. PPOs are evil. I'm going to say that again. PPOs are evil. I think if you're here, you pretty much agree with that. But that's
tell me how you really feel about it.
Oh yeah, no, that's PPOs are evil. Did I say that? But that's another challenge. Is many of these large employers, and this is why what you guys are doing here is so important. Many large employers think that they are saving money because they're a self-insured plan through Blue Cross or one of the big plans. They're saving a little bit of money in comparison to the absolute fleecing that they were taking on the fully insured side. But their patients or their employees aren't saving that money, and really the plan isn't saving that much money from an employer standpoint.
Who here thinks that it is the job of the insurance company to negotiate the best rate for the customer? By a show of hands, who thinks that? Who thinks that is supposed to be their job? Thank you for having me clarify the question. Who in here thinks that is what effectually happens? Nobody. Because we see the reality of it. And that's why we see from, the brokers and the agents and the advisors here this weekend, and the work that, the Kempton Group is doing, you can see. But why is that the case? Does anybody understand why there's no incentive for the insurance companies to negotiate the best rate? You'd think it would be in their best interest. There's a component of the ACA called the medical loss ratio. They're supposed to spend 85% of the premium dollar on clinical services. Well, that's kind of a vague definition as well. So they can only keep 15% for administration, right? And profit. How do you increase a percentage? Well, you spend more money. Yeah, there's no motivation. The motivation is actually perverse. It's inverse. So you're negotiating higher rates with the hospitals and blaming the bad hospitals on the increased premiums. And so the pie just gets bigger and bigger and bigger, and that's what we've seen over the last 10 years.
There was a presenter here at FMMA 2 years ago, And he had this outstanding chart. I saved it, shared it with several lawmakers, and it showed the stock price of essentially the holding companies of the top 5 health insurers. And all of them had grown a minimum of 500% over a 5-year period from 2010 to basically in the middle of the Obama administration. So that's proof that they're in the game. They need prices to increase. And like I said, I worked at the insurance department, so I would know how insurance companies work. If you want to invest more, you need premiums to grow. And the one way to get premiums to grow in healthcare is to raise costs. And so then you pretend one of the hospitals that had sued had filed over, I think it was over 6,000 lawsuits. Every year, they're locked in this big, gigantic drama that's in the paper. St. Francis Hospital and Blue Cross Blue Shield can't agree to a rate. And it looks like this fanfare, and the public thinks, wow, they're really duking it out. And then magically, right before the plan year is supposed to end, I mean, I literally just saw the article while I was sitting in the group there. St. Francis and Blue Cross begrudgingly agreed to a rate. And now the 60-plus doctors that are at St. Francis will now be able to see their patients at Blue Cross.
Yeah, that's who the pawns are. The
Right.
pawns in that big theater is the doctors and the patients. Really the only 2 stakeholders in the healthcare industry. That should be the case. It's really quite disgusting. Jay was talking about, and even Jonathan, what we are doing here, what this movement is doing, is so incredibly important. This is where the feet are. This is what's happening to show that it's not theory. It's the proof in the pudding. I get asked all the time, how are we going to fix healthcare? At times, it depends on the day when you catch me. There are days when I think it's irreparable. That's kind of where I am. But that doesn't mean we don't push back and we don't spread our message. But at the same time, we've got to create a parallel system that will force them to compete. That's the direction we need to move in. That's the direction we are moving in. And that's why I'm extremely proud to be a part of this organization and this event this weekend.
All right, so we can both be on time. We're going to end. We'll stay up here up front. If you want to come up and ask us, I can find you quickly who your state policy network affiliate think tank is, and then we can give you guys our contact information and stay in touch. Thank you very much.
Thank you.